Traction splints are used specifically for mid-shaft femur fractures. The devices are contraindicated for fractures involving the knee, ankle, or hip joints. The hair traction splint braces the leg between two metal rods, while counter traction is applied in an attempt to keep the bone ends from overriding one another. The hair traction will be shown first in this video. Femur fractures can potentially sever the femoral artery, causing massive bleeding of up to 1 to 2 liters of blood in the thigh. If the patient shows signs of shock, you should immobilize the entire body to a long spine board and transport without delay. If resources permit, you can then apply the traction splint en route to the trauma center. In some situations, patients will present with a compound fracture. Compound fractures should be covered with a sterile dressing prior to application of the splint. This will help prevent further contamination of the wound. Do not push bone ends back through the skin, but be aware that bone ends may relocate themselves when traction is applied. If this happens, remember to report it to the emergency department. In many cases, traction splinting will not occur until the patient is already packaged and en route to the trauma center. Begin the procedure by taking BSI precautions. Explain traction splinting to your patient, gaining his or her consent to perform the procedure. Many patients do report feeling a great deal of pain relief once traction is applied. Expose the leg if possible. It is not uncommon for the leg to have bruising or deformity given the amount of blood that can collect in this space. Assess PMS, pulse, motor function, and sensation distal to the injury. If necessary, move the leg into neutral alignment. Otherwise, stabilize the injured leg by applying manual traction. Once traction is applied, however, it cannot be released until the splint is fully applied. Place the splint at the level of the ischium, then adjust it to the proper length, approximately 8 to 10 inches beyond the foot. Measure on the uninjured side. Position the splint under the injured leg as shown. Make sure the ischial pad rests against the bony prominence of the buttocks. Once the splint is positioned, raise the heel stand. Apply the proximal securing device or ischial strap over the groin and thigh. Next, secure the ankle hitch. The rescuer who secured the strap can now take over maintenance of manual traction. Apply mechanical traction using the hand crank on the device until relief is felt. Fasten the leg support straps. Do not place straps over the injury site or knee. Then, reassess distal pulses, motor function, and sensation. Note any changes from your initial assessment. Move and secure patient to a long spine board for transport if you haven't done so already. Be sure the splint itself is secured to the board to prevent movement and further injury. Many elements of traction splinting are the same regardless of device used, such as BSI, gaining consent, exposing the injury, checking PMS before and after application of the splint, covering a compound fracture if necessary, and reassessment. But let's look at a few steps that are different if you are using the Sager splint instead of the hair. Hold manual stabilization of the bones above and below the injury site. Measure the splint to 4 inches beyond the foot. Unlock the clasp to extend the heel. If possible, measure the device on the opposite extremity to avoid bumping and further injury to the extremity. Position the splint medially between the legs. The splint will need to be adjusted high into the pelvis until it meets the ischium. Secure the hip strap. Be sure it is snug without reducing distal circulation. The strap will keep the splint in place when traction is applied at the opposite end. Apply the distal securing device or ankle hitch. If a sock is present, remove it before applying the hitch to prevent the ankle hitch from moving. Release the lock and apply mechanical traction by extending the distal end of the device until relief is felt, or you have applied traction equivalent to 10% of the patient's body weight in pounds, or a maximum of 15 pounds. You will need to use counter pressure when pulling traction to ensure the splint does not move. Secure the device using straps on the proximal and distal lower extremity and the knee. The legs can then be tied together to further immobilize the leg. Avoid placing a strap over the injury site.